Topics you meant, or
Testing. Okay. Everyone ready? Can we all sit down, please?
I know.
Thank you. So thank you, everyone, for coming out tonight. This is going to be great. I'm going to hand it off to my co-director, Dr. Cody, to start the night off.
Hello, everyone, and welcome to our annual Dalhousie Sport Medicine Research Night. We are thankful and happy to see everyone here tonight. This evening, we celebrate our outgoing fellows, highlight our successes throughout the year, and most importantly, show our gratitude for those who have helped us along the way, all of you. Thank you for coming tonight, and we look forward to sharing our year with you.
Hey, good looking, why the frown? You always look better when it's upside down. You say you got nowhere that you're going to. Can I go nowhere with you? I took the Dartmouth ferry into the town, spent my pennies bumming around, trying to find a way to tear a strip off these blues. Can I go nowhere with you? Paid the cover, saw the show, sat at the bar where the drinks did flow, didn't see a single face that I knew till I went nowhere with you. Can I tag along tonight? We'll kill some time. It looks like you might need a little company. I'm so cheap, I might as well be free. Hey, good looking, why the frown? You always look better when it's upside down. You say you got nowhere that you're going to. Can I go nowhere with you? Here we go. Na 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 na. Can I go nowhere with you again? Na 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 Can I go nowhere with you? Can I tag along tonight? We'll kill some time. It looks like you might need a little company. I'm so cheap, I might as well be free. Whoa, 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 whoa. If you get tired and want to go home, I'm still wired, I can go it alone. Same time next week at 10:15, and we can go nowhere again. If you show up then you know I will too. Can I go nowhere with? Hey, good looking, why the frown? You always look better when it's upside down. You say you got nowhere that you're going to. Can I go nowhere with you? Hey, good looking, hey, good looking. You got nowhere that you're going to. Can I go nowhere with you? Can I go nowhere with you? Can I go nowhere with you? Can I go nowhere with you?
So I must say I'm super excited because this is the 11th year I think we're doing this now, and every year it seems to be getting better and better. You can see kind of from our highlight reel. We'll go through this a little bit more about what has gone on, but I am super proud of our team. We've been all over the world this year, many conferences, so we'll go over that. So tonight's going to be different. We decided to change this up because we've experienced a lot of different things over the past year. We've changed up all kinds of conferences, and we kind of took the best of what we saw, and we have a fantastic panel of judges here tonight. So normally we do research night, and we kind of do our presentations, but we're actually going to have a contest. We're going to have a judging of how it goes, and we're going to have discussion of these. So we are going to welcome our fantastic panelists. I want you to help me thank this first one. Of course, is my co-director, Dr. Kathy Cody. She's an associate professor here at Dalhousie. Would never be the same. I'm so thankful because, again, I trained under her as a medical student, and this is probably the most fun job I've had to be able to work with her. So thank you, Dr. Cody. Of course, right next to her, we have a fantastic leader, Dr. Gail Thomason-Murphy. She's with she runs the Innovation and Research Hub here at Dalhousie and Nova Scotia Health. She's in charge of many different things. I'm super excited. I know she's putting Dalhousie to Halifax, Nova Scotia Health on the map, and I'm really excited to work with her. I'm really excited to see what she's going to have to say from our great research from our fellows. Then we have Dr. Mark Sorrento. Mark Sorrento has been with, actually, I've met him since I came back to Dalhousie. I guess this is almost 12 years now. He's been in the OR from day one when the OR was dripping water on me. It has been a phenomenal journey to be able to discuss with him all the different things that have been going on in the world of sports medicine. So we're really excited to have him see what we're doing here. And of course, last but not least, we have Dr. Derek Rutherford, Associate Professor here at Dalhousie. He's also Interim Director of the Physiotherapy, School of Physiotherapy. He's been working with us, again, ever since we've been back, looking at, trying to look at more than just knees and looking at a lot more shoulders and hips, and even having a PhD candidate that we're working with together. So really excited to have Dr. Rutherford here with us tonight. So it's my honor to bring up our first presenter tonight. This is our fellow, Dr. Kazu Kaziki from Japan. Why don't you come on up, Kazu? He's going to come talk to you about bridging reconstruction for large and massive rotator cuff tears, their outcomes, what they've been doing. He's been following our data very closely. He's been becoming a name for a presentation. People are coming to watch him talk, and it's become the most popular viewed View Medi program in history, okay? So please welcome Kazu. Take it the other way. Swap? Here. We'll swap. Yours.
Good mic. That's my mic. Thank you. I want to tell you before my presentation, I'm the first Japanese orthopedic surgeon in Nova Scotia. That's enough. Too much. Thank you. So this is my last presentation in Canada. So my talk, Bridging Reconstruction for Massive Rotator Cuff Tears, has a high survivorship rate against reverse total shoulder arthroplasty at a minimum 5 years. We went to Boston, Fenway Park, okay? And Japan is a baseball country. And I'm so exciting moment with Mike. Mike is striker, yeah. So he's a great Blue Jays baseball player. So every day in Scotia, we chatted a lot about baseball games. So baseball, Japan, but everybody has rotator cuff tear. So rotator cuff tear is a big #1 shoulder pathology. And unfortunately, 40% cases, massive rotator cuff tears. And extremely challenging to treat massive rotator cuff tears. The history of treatment for massive rotator cuff tears initiated about 40 years ago, about just major debridement and partial rotator cuff repair and a tendon transfer. About 15 years ago, bridging reconstruction, SCR, and balloon implantation have been introduced. Bridging reconstruction has been initiated by Dr. Steve Snyder in 2008 and developed by my boss, Dr. Ivan Wan at Dalhousie. However, we do not have enough data. What's going on after 5 years? So that's my research topic. So this study was to identify the survivorship against reverse total shoulder arthroplasty at a minimum 5 years. The eligibility criteria, the patient followed at least minimum 5 years after bridging reconstruction for massive rotator cuff tears. The primary outcome, survivorship against reverse total shoulder arthroplasty. Also, patient-reported outcome measures and also progression to rotator cuff arthritis. So we follow a total 44 patients at a minimum 5-year follow-ups. The average 7.3 years. Significantly, the patient-reported outcome measures improved at baseline 71 down to 24. And also, 95% of cases achieved minimally clinically important difference, meaning very happy. And also, one patient had reverse total shoulder, meaning 98% cases survivorship rate, and also 95% of survivorship against end-stage arthritis. Also, usually if proceed with arthritis, the humeral head migration upward, meaning acromion humeral head distance becoming smaller, but we maintained about 5.3 millimeter in average. That's fantastic outcome. And a recent systematic review showing several treatment options for bridging for massive rotator cuff tears. And the bridging reconstruction is a potential best. And recently, I made a wonderful video. That's on the Bumedi, okay? And we made a poll there. Everybody in the world, which treatment is best for you for massive rotator cuff tears? Look, the majority of the audience selected partial repair. We completed a randomized control trial. Partial repair, bridging reconstruction. The answer is bridging reconstruction. Again, I want to tell you, okay? In the 1 month, over 2,000. And now, over 2,500. The #1 viewing video for massive rotator cuff tears. Who made it? Me. Who's my boss? Him. In conclusion, bridging reconstruction for massive rotator cuff tears has an excellent survivorship against reverse total shoulder arthroplasty at a minimum 5-year follow-up. So next journey, going back to Tokyo. Thank you. Thank you.
Good job. Thanks. You just leave that right there. Okay, good job, Kazu. Hopefully you see now why he's been hotly regarded for the next center. So we're going to go on to our panelists. Panelists. Comments, questions?
Yeah, you're not going in.
Okay.
Yep.
Okay, #1, please. Thank you so much. Thank you so much. That's enough for me. I just want to put my name in your memory. That's my dream.
You're not getting off that easy.
Thank you.
So, as in my work in Nova Scotia Health, what we're really mostly concerned about is the impact on patients. So you've had all kinds of views and great video, and you're part of Ivan's work and brilliant. So I really want to know, how are you going to take what you've learned and that preference and your study, and how are you going to take that to translate that into the place where I work in practice? Tell me more about that.
That's a great question. before I came here, I studied our health research methodology at McMaster University with Dr. Ofemi Ayani, the research head, and Dr. Wan's close friend, and also Dr. Gordon Guyard, our evidence-based medicine. And the keyword, knowledge translation. Many people are doing great job, great paper, that's it. But it's extremely challenging, a big hurdle, a big wall to get into practice.
Yeah.
So the key is my perspective, just broadcasting, and try to appeal orthopedic surgeons, not only in Canada, not only in Tokyo, but everywhere. It's a good option instead of partial repair. That's a key. Knowledge translation, extremely challenging, but we have to do, and I believe I can. That's why I decided to change my personality. I'm a Japanese person. I'm super shy, but it's not good to change into knowledge translation. That's my answer.
I love it, thanks.
Thank you.
Yeah, really. Oh my goodness.
He was when he started.
Right. Dr. Cody knew everything.
Very true. If you ever watched his first presentation to the presentation 1 year afterwards, this is a Kazu we never thought we would see
That's right.
or end up with.
That's right.
Any other questions from our
I
esteemed
can
panel?
follow up.
Yeah.
Kazu, great presentation. And I'm wondering, Dr. Cody and Dr. Tomlin Murphy, if they came to see you, how would you treat maybe them differently based on what you found? In your results, you said 70% of your group were male. I'm wondering what implications does it have for females that come in to see you as we sort of translate this out? Or does it?
Oh, that's a great feedback, because orthopedic surgeons only care about result, and we don't care among social background. But for example, male physical labor is usually soon after going back to return to work. So usually a little bit successful rate lower. So female are so. The answer is still we have to do research more. So please
Good answer.
edit.
Okay.
Great point. Just on the point, but that's beyond my capacity. But anyway, I want to tell you, we have to think about all patient background, not only male, female, work type, and what kind of sports.
Nope.
Thank you. Great feedback. That's my
Great.
future work.
Cheers.
Wonderful. Any other questions? It's good. Okay, so now we'll go to the judges. So judges, we're going to base it out of 10. We're going to come up with an average score because we have an awards right after our 5 presentations. Scores?
We put him up.
Yeah, put them up so everyone else can see. 8, 5, 9, 90, 99. I think we're at a 10.
Mark is my best teacher.
8, 9, 9. Okay, okay.
Minus
Good
9
job.
points.
Good job.
Gotta make room for the other ones.
I know.
Okay, I was told to switch mics. So, our next presenter, our other fellow, Dr. Luke Heinrich. He comes to us from Edmonton with another fellowship in arthroplasty. I know we've spent a lot of time convincing that arthroscopy is different, and I think there's been a change over the past year. It's been wonderful. So we'll have Luke come on up. He is going to, I think we're going to talk about him a little bit more later for our fellowship review, so you'll hear a little bit more about Luke. We do have a timer for this one. It's right here in the front, just for you. Here's your, yeah, do you see that? It's black. This is black on black, so it's hard to see.
Oh, thank you so much.
And your flipper.
Perfect. Well, that's a tough act to follow.
Yeah.
But everyone, my name's Luke. I'm starting practice in Medicine Hat next month, but thank you for your attention about my talk about non-rigid fixation, comparing button versus, I have nothing to disclose. Here's Dr. Wong's disclosures. So to get right into it, AEGR, or arthroscopic anatomic glenoid reconstruction, is an emerging technique for shoulder instability. As we recognize more and more the contribution of bone loss to this issue, we're recognizing how important addressing the bone loss is to our patients. Similar to Latarjet, different techniques have been described for AAGR, using either a screw or a button for fixation of the graft. There's been concern in the past about screws causing irritation of the subscapularis and subsequent hardware removal. But buttons really have their own concern for this issue. Our group presented last year our findings of an extremely high failure rate and worse outcomes for patients with button fixation. So our purpose of this study was really just to examine that, these cases of failures after AAGR, and to see if we could identify some cause or reason for these poor results amongst these patients. So what did we do? We looked at, this was a retrospective review of these patients receiving AAGR between 2013 and 2019. Basically, we had 18 patients with button fixation who were matched to 18 patients with screw fixation. 7 patients with failure were evaluated and compared to the remaining successful patients. For this review, we used arthroscopic video recordings. We looked at multiple things for graft placement. We looked at the superior inferior position, the medial lateral position on the glenoid of where the graft was situated, and finally whether the graft appeared flat, concave, or convex. We also looked at the interface for gapping. For soft tissue, we looked at the overall appearance pre-repair as well as the quality of repair afterwards. Finally, we took note if there was a presence of a remplissage and presence of a Hill-Sachs. We also did include patients' post-operative imaging in this analysis along with their demographics. When analyzing the failed patients, our initial impression is that there was really not anything significant. Grafts all appeared in a reasonable position. We did notice soft tissue quality was concerning in about half of the patients, which is really unsurprising considering this population is high incidence of poor soft tissue, high rates of revision. But we found really all these patients had a good looking soft tissue repair covering the graft at the end of the case, with only one having a partial coverage of the graft. When we compared these cases to successful patients, we started seeing some differences. Initially demographics looked similar, soft tissue quality was poor across the board, and the rate of remplissage and Hill-Sachs was similar. But when we looked at cases of successful cases, we started seeing that compared to the cases of failure, there was a much higher rate of the graft in successful cases being perfectly flush and perfectly compressed. Now, in the failure patients, this, the malposition was very, very slight, so it might sound like I'm being very critical here, but this was what we did notice as we reviewed these cases. And this really makes sense because as we've developed the technique using screws, we found that screws compared to buttons really allows for a whole amount of fidelity in adjusting that graft to just the perfect position where we want it to be. Post-operative CT showed similar differences. Again, we saw that the button patients did have slight graft medialization and slight gapping at the interface. Also, most notably, we did see on the post-operative CT that the AP diameter was much smaller in the patients who had failure. So there certainly seems to be a subset of cases where, not only does the graft resorb, remodel and grow smaller, it actually kind of just resorbs, and these patients just really do not do well when there's significant resorption. So what's the relevance of all this? I think the process of graft remodeling and incorporation is really poorly understood. I think if anything here will really highlight how many questions remain in and around this topic. First, we did see more slight medialization of medial displacement in patients with button fixation. I think it makes sense that even small displacements could alter loading of the graft against the humeral head. If we think of AAGR as remodeling, this could be important, but really at this point, this requires further study. Secondly, we might assume that a compressed interface, like what we saw with our screw patients, and zero gapping is better. But at this point, we do not know if there's a certain range of acceptability in this regard. We do know from impaction grafting that increased compression will actually release more BMP from a fresh frozen graft, which is probably or could be helpful. But really, grafts are a complicated process balancing resorption and remodeling. And I think it's fair to say at this point we just don't fully understand this process. Third, there's been multiple biomechanical studies comparing screw and button fixation for both Latarjet and AGR. Screws have generally been shown to be similar in load to failure, but most notably what is often not mentioned is that the button patients do have a higher displacement under load, especially at higher loads. It is not really known at this point how much graft displacement and micromotion can we accept during the healing and incorporation process. Is 1 millimeter significant? Maybe less. Additionally, I think we can all recognize that whether it's AGR or Latarjet, that grafts do become smaller over time. If you think of a button construct as, when it's properly tensioned, it acts like a rivet or a rigid construct, but as the graft gets smaller, that button can get loose and no longer is holding the same. So, what we don't know is, does the graft incorporate and heal on before the button becomes loose? Really, this is another question that probably requires further study. So to conclude and summarize, we found a high rate of failure in our patients with button fixation. Review of the cases of failure did not find an obvious technical error. Comparison specifically to patients with screw fixation did show a higher rate of the screws being perfectly flush and perfectly compressed. I think we recognize that this is a limited series of patients, and I think if this anything, this study does highlight how little we know about graft incorporation and remodeling. I think we need to better understand which cases go on to remodel and which will go on to fail. Thank you.
Thank you, Luke. Questions from our panelists?
Just curious, were you able to divide the ages? Because I would have a thought that if you had a 16-year-old versus a 36-year-old, that you would probably get fast. It's always a race to the heel, right? So did you subdivide your age groups to see if, like, the 16-year-olds had a better healing outcome than the 36-year-old, for example?
Yeah, I think that's a fair question. But we got our CT at a fixed interval, but we did not do subdivide patients based on age for this analysis. But I think it's a fair question. But I think we need more data in the post-operative period to further analyze that between different age groups.
Because do you think it's a little bit of a race in the sense that that maybe if you had a younger patient, it wouldn't matter what type of fixation?
Yeah, I think it's a fair question, and certainly we've seen good results, using button fixation for like a Bankart fracture type patient. But I think, like I said, I think there's a lot of intricacies here that I think we just need further study to better understand.
So
thank you for the question.
Luke, were these matched patients? Were they matched by age, gender?
Yes. So, I think I was understanding the question maybe in a little bit differently than Dr. Wong, but certainly these were age, demographic matched groups that we were comparing.
Great. Question? Yeah.
Yeah, thanks, Luke. That was great. And let me acknowledge first, I really like the Nova Scotia Health Authority logo on yours. That's where things happen in the ORs. Thank you. So what my question is really is how are patients responding to this kind of, responding to the studies? And do you have any scores that actually speak to the patient experience or to their engagement in this kind of work?
Right. So I think overall it's important to understand that, bone grafting, the glenoid, is a rather niche surgery still. I think more and more I do see under like a common knowledge of the different options for this kind of surgery in patients, especially athletes. In terms of outcomes, I mean, we do outcome measures on all our patients, and certainly we have shown better outcomes in our patients that are not dislocating, and that's kind of what we really highlighted last year in this specific group of population. that the patients with screw fixation that weren't dislocating were a whole lot happier.
Thanks, Luke.
So just out of curiosity, for Luke, what are the pros? Are the pros measuring patient satisfaction and happiness? What does WOSI measure?
I think my understanding is it's like an overall score of satisfaction, pain, and function.
Yeah. So this is a patient-reported outcome with no surgical or team intervention, so complete patient perception, including physical, emotional, outcomes being validated for that. So essentially coming out with the patient satisfaction. Great.
Thanks, Adam.
Any other questions?
Sure, I can ask a question. Yeah, sure. Thanks, Luke. And this is probably my ignorance to this, but the success versus failures and the idea of what I read end of case. So what is an end of case? You mentioned it in here. The end of case, so what does that mean?
Oh, sorry, just at the completion of the procedure. So
It's like the surgical procedure, or the case is
That's
like
right.
closed? Oh, okay.
that's probably what I was referring to, if I'm understanding it correctly.
Okay.
But, basically we would, end of procedure.
Okay, thanks.
Great. Okay, so what are the scores from our judges? You guys all ready? With 8, 7, 8, 9. Very good. Thank you. So thank you, Luke. I forgot to mention as we keep going here, this is actually being streamed live on YouTube. We have a bunch of people watching, so just as a note for anyone who's watching, that you can write the questions on there and we can ask the presenters live. And we are going to have a few of those who are streaming that are going to be part of this show tonight too. So we get to move on to our third presentation. We get to welcome Dr. McKenna to come up. McKenna is actually one of our future fellows. She's currently doing her upper extremity fellowship here at Dalhousie. She comes to us from Kenya. Has been widely known on social media, so though we haven't had her on our fellowship program yet, I'm able to follow her everywhere around when I ask my team to look on her Instagram page. So she's going to come talk to us about patients with either comorbid spine or other major joint pain have equivalent outcomes to patients with isolated hip pain after hip arthroscopy for FAI. Thanks, McKenna. Oh, where's the clicker? Anyone have a clicker?
Uh-oh.
Luke?
Luke's pocket.
Thank you.
Thank you, Ivan. Thank you so much. Good evening, everyone. Dr. McKenna, as you have heard, and I've met most of you. Thank you so much for making my 1 year here in Halifax be so memorable that I decided to stay another year. And so my journey into sports medicine begins with me exploring down south from where I've been in the shoulder and elbow, talking about the hip. These are disclosures. So over the recent decades, hip arthroscopy has become quite a popular surgical procedure for femoroacetabular impingement and labral tears. It's generally quite successful, high rates of return to sport, limited complications, and relatively rapid rehabilitation rates. And although it's quite popular and has quite good outcomes, we still have a few patients who are yet to achieve full satisfaction, and therefore postoperative efficacy of these procedures need to be identified due to the evolving nature of the hip arthroscopy. So when we look at joint arthroplasty literature, it does show that musculoskeletal morbidity, that is pain in the spine or any other joint, for example, the shoulder, knee, or ankle joint, does affect or has a relationship with outcomes. And we extrapolate that any pain in the spine or other major joint may have an influence on functional outcomes after hip arthroscopy. And the literature does suggest that the prevalence of associated knee, shoulder, or spine pain occurs around 30 to 40% of the time. And this association is explained by shared etiologies, for example, overuse or similar mechanisms of injury, compensation and kinetic chain relationship, muscular interplay, and systemic factors. So the objective of this study was to determine if patients with pain in the spine or another major joint have worse preoperative and postoperative patient-reported outcomes than patients without any comorbid orthopedic pain. And as in the previous study, our patient-reported outcomes are all patient-reported and based on satisfaction. We identified, or rather, included patients who underwent hip arthroscopy at this facility, Nova Scotia Health, between 2016 and 2020, and had an available preoperative diagram as shown. We excluded any ipsilateral hip surgery or any other additional surgery that took place within 6 months other than the contralateral hip. We then graded the patients according to the musculoskeletal morbidity grading by, as described by Huber et al., whereby grade 1 patients only had pain in the index hip that was being operated on. Grade 2 had hip pain in another major joint, so that is either the shoulder, knee, or ankle joint. Grade 3 had index hip pain and associated spine pain, and grade 4 had all the above: index hip pain, spine pain, and another pain in another major joint. And the outcomes, as mentioned, we used the IHOT, that's the International Hip Outcome Tool, and the Hip Outcome Score Activities of Daily Living in the four categories. We had 131 patients that we included in the study after inclusion and exclusion criteria. And as you can see, age, BMI, and duration of follow-up were statistically not significantly different. We do note that there's a variability of patient numbers, particularly in grade 4. However, gender was the only identifiable factor that had a difference, and we do know that females are significantly more affected by femoroacetabular impingement due to anatomical differences, preferential participation in activities that cause repetitive movement around the hip, and also hormonal changes. And actually, female gender in itself is an identified negative prognostic factor for hip arthroscopy outcomes. So when we look at the preoperative results for both outcome measures, patients in grade 4, that is patients with index hip pain, spine pain, and another major joint, significantly had lower IHOT 33 scores as compared to group 1 patients, which are the patients with only the index hip. That's also known as the control group. And there was no difference between the groups 1 and 2 and 3, which is either isolated hip pain plus spine pain or other major joint pain. When you look now postoperatively, we can see that there was obvious improvement in outcomes. All the 4 groups, there was a significant improvement in postoperative outcomes in the IHOT 33 scores, and this shows that hip arthroscopy for femoroacetabular impingement specifically provides benefit to all populations, even in the presence of concomitant spine or other joint pain. When we did the same with the hip outcome score, there was a statistical difference between group 1, again, and group 4 patients. That is the control group and the group of patients that had the pain in the hip, the spine, and another major joint. And hip outcome scores of activities of daily living for group 4 participants also showed improvement. That is pre versus post-operative. You can see there's an improvement in the second graph, albeit not being statistically significant, but there was an improvement. Finally, we also did the minimal clinical important difference of the 4 groups. You can see that all 4 groups achieved MCID, and also the patient acceptable symptom state was achieved in all the 4 groups. For the patient acceptable symptom state, there was only a statistical difference between the control group and the group 4 patients that had all the associated comorbidities. So there's actually literature out there that suggests that hip arthroscopy for femoroacetabular impingement does not only improve hip function, but also the back spine function as well, just because of the kinetic chain interplay. When one joint is back functioning well, then the other joint will follow suit. And therefore, as we have also seen in this study, that it's important to consider the overall comorbid and systemic conditions of the patient, but we do suggest that additional either major joint or back pain significantly benefit from hip arthroscopy for femoroacetabular impingement, and a combination, however, of the comorbidities, that's with the grade 4 patients, are the ones that may report poorer outcomes. So this finding is specifically important to put into consideration when we are screening our patients preoperatively, when we're talking to them and making the shared decision process, managing expectations and rehabilitation strategies, including physical therapy. So we conclude that femoroacetabular impingement treatment with hip arthroscopy yields improved postoperative patient-reported outcomes and actually have equivalent to patients with isolated hip pain. Thank you.
Thank you, McKenna. Questions? Audience? Panelists?
I'd
Gail.
love to ask. Thanks.
Thank
Your
you.
study was great, and I think really what you've demonstrated is the importance of that post follow-up care, and I really like that. And so, can you tell us a little bit more about how you take your findings and translate them to practice, and what kind of study are you going to do next?
I'm just literally starting out, so what I'm going to do next is going to be incredible, having an amazing team like today. But from what I picked from this study is patients are not just a hip or a shoulder or a knee. They come into the office with several complaints. Usually come with one main complaint, but they also have pain in other joints. And for example, if they're sports people or they're dancers or people with involved in physical activity, then they do have pain in other joints. So how I translate this is, first of all, history taking. Make sure you get all the proper information of all the joints that may be affected. Any treatment that we do before surgery, physiotherapy, exercise, stretches, all that does not only affect the index joint that we're planning to operate on, but also other joints as well. When we're speaking to them about expectation management, like what do you expect after? What kind of return to sport do you expect that you'll be able to do? And when we speak to our physiotherapy departments and occupational therapy and all those, what are kind of the expectations that we expect to get from these particular patients who have not only one joint affected, but multiple joints affected? So I think the patient needs to be considered as a whole and not just one joint.
Okay. Thank you.
Yes.
Just a lead up on that, McKenna. Thanks very much. That was a great presentation.
Thank you.
But is that part, what you just discussed, is that actually the perioperative screening that you mentioned in your final part of the presentation?
Yes. So when we analyze all the patients, and this basically comes from I know we have some medical students in the room, the importance of taking history physical examination from the beginning. So that all is done with our team. We have the form that I showed that actually identifies not only the joint that you've come in, and like the referral system we have in Nova Scotia, you come into the clinic for a specific problem, but we're able to collect the data on all other comorbid orthopedic pain and use that information to create a plan that is suited to whoever it is that we're seeing. So yes, it is part of the pre-operative evaluation that we do for all patients.
Thanks, ma'am.
Yes. Thank you.
Oh, there's a question out here.
I guess as part of, I'm not sure, part of the chart review might have been whether or not there was a diagnostic local anesthetic injection to the hip joint and how much of a predictor that may have been to how well people are going to respond to the hip arthroscopy.
Yeah, so thank you so much for that question, because this is something that came up as well last week when we presented this in COA. So specifically for this cohort of patients are surgical patients, so patients who are actually managed surgically, meaning they've already kind of failed conservative management. But one of the other things that we're going to look at is now all our patients who present to us with femoroacetabular impingement. Not everyone undergoes surgery. A lot of them actually recover well with conservative measures, and an injection is one of them. So if we group them in the different 4 groups and they undergo conservative management, we're going to look at if that also has a difference, as we've shown in the surgical group. So that's part of work coming forward, for sure.
Thank you, McKenna.
Thank you.
Good work. Okay, so we're going to move on to our next talk. We get a welcome. Sorry, I forgot. Thank you. We need the scores. This is super important. Scores, judges. 8s, 9s across the board. Very nice. Well done. This is going to be hard to figure out who's going to win here.
Oh my God.
Oh my goodness. Okay, so we're going to move on. This is Dr. Shar Sadai. So for Does it heal? A second look analysis of capsule, labrum, rotator interval after arthroscopic glenoid reconstruction with extra-articular graft. Shar is one of our PGY5s who's just finishing, who I have unsuccessfully convinced to go into sports. However, we still have time to work on him.
One more year. Thank you for the introduction. I'll get into it. I have no conflicts of interest. Anterior shoulder dislocation is a common shoulder injury. It has a rate of 1.7% in the general population.
Sure. Mic up.
And thank you. And it has a high recurrence rate amongst the younger patient population, military personnel, and contact athletes. The essential lesion is the Bankart lesion, which is the disruption of the anterior labrum, but it can also be associated with a Bankart lesion, a bony Bankart lesion, which is present in 22% of the first-time dislocators. In their landmark papers, Burkhardt and De Beer showed that more than 2/3 of patients who have greater than 25% glenoid bone loss experience redislocation. This is as opposed to 4% recurrence of redislocation with no glenoid bone loss. So they recommended a bony procedure when there's a critical bone loss level of 25%. Later, authors have revised this level to 10% from 25 for recommendation for a bony procedure. The current options include a ladder J, which is a gold standard, but it is a non-anatomic procedure and it has a high complication rate and a steep learning curve. And this is as opposed to other bone grafting options, for example, using iliac crest bone graft and distal tibial allograft. We have previously published in our results patient outcomes regarding anatomic glenoid reconstruction with distal tibial allograft. It's a safe procedure, it's reproducible. It has high rates of graft union, improved patient outcomes, low complication rates, and it has a quick rehab. But there's a lingering question of what happens to the soft tissues that we are involved in this procedure. Namely, we take down the rotator interval extensively to place our bone graft. Does that heal? And what happens to the capsulolabral tissues that we attach to native glenoid? Does that heal? So that's the objective of my study, is to assess the healing status of rotator interval, labrum, and capsule in patients who had a revision arthroscopy following an index AGR with distal tibial allograft. We performed a retrospective single center case series. We had more than 200 patients eligible, and we included patients who had a subsequent revision surgery. Out of all more than 200, only 10 people had received a revision surgery. And we excluded patients with immunocompromised status, diabetes, or if they were missing intraoperative videos. All of that amounted to one person. We had 9 patients in our final analytic pool, mean age of 40 years of age, and average time from index to revision was about 3 years. 3 people experienced stiffness in our cohort. 1 person had subjective instability afterwards, and that was due to graft resorption. And the majority of people had symptomatic hardware, which was the main reason for getting the revision procedure for hardware removal. Out of our entire cohort, we looked at the arthroscopic videos and assessed the labrum, the capsule, and rotator interval based on a categorical variable. So if each of those structures were fully healed, they will get an F. It's not for fail, it's for fully healed. And P for partial and N for no healing at all. So in our patient cohort, 89% of patients had full healing of the soft tissue structures. And only 2 patients had accounted for our poor soft tissue healing. This is patient 2, who had partial healing of the rotator interval with a small central defect shown by the red arrow in image A. Interestingly, in this patient, the middle suture had failed by pull-out, but the overlaying capsulolabral tissue had healed. We dynamically pulled on the tissue and showed that it was well attached. And we had to dissect about 3 to 5 millimeters to expose the screws that we had to take out. And this is patient 5, who had an anterior-inferior defect of the capsule and the labrum. We were looking at the 5 o'clock position from the anterior-superior portal and seeing the inferior screw is exposed. And looking from the posterior portal at the 3 o'clock position, there was soft tissue covering the superior screw, so there was some partial healing. But this was quite thin. It was about 1 to 2 millimeters dissection to get to the superior screw. This patient had, interestingly, had not received the Bankart repair in the index surgery, and the graft glenoid junction that you see was left as is. So partial healing had happened by itself. Despite those cases that were shown, majority of our patients were fully healed, 89%, and these are representative images of the rotator interval on image A, and of the healed, fully healed capsulolabral complex over the graft glenoid junction, seen through the anterior superior portal. Comparing to the literature, there aren't actually that many studies showing outcomes of soft tissue healing. Zhao et al. In 2014 reported on 52 patients who had recurrent dislocations that subsequently had iliac crest bone graft that was allogenic, and they repaired the capsulolabral tissue to the native glenoid, just like our technique. They had a follow-up MRI at 6 months in all 52 patients, showing good healing of the bone to capsule structure, and only one person showed poor healing, and they had experienced an episode of instability. In a shorter case series by Bachman, they presented on 9 patients who received arthroscopic iliac crest grafts, and they repaired the capsule and labrum to the outside of the graft, so they kept the graft intra-articular. At an average of 3 years in a postoperative MRIs, all grafts had remodeled and capsulolabral tissues had healed. I think what this study adds to the literature is that it's the first study assessing the healing of these soft tissues arthroscopically, which is a better standard than MRI, and we dynamically tested the tissue. And as far as a case series goes, it's a single surgeon with a single center design that limits variability of outcomes with respect to operative techniques and postoperative protocols. The main limitations, of course, being that it's a retrospective study with small number of patients and no comparison group. In conclusion, at 3 years of follow-up, patients receiving AGR with a distal tibial allograft demonstrated excellent healing of the labrum, capsule, and the rotator interval at a rate of 89%. Thank you.
Great job. Questions?
What do you think contributed to the really high healing rate of the tissues?
Excellent surgeons. No, I think part of it is reattaching the capsulolabral complex to the native glenoid, which is a bleeding bone, rather than to the outside of the graft, which is essentially a dead tissue. So I think that contributes. But even without doing the Bankart repair, we saw that 2 of our patients, before our technique was reattaching the capsulolabral to the native glenoid, they heal on their own because they have the capacity for that. It is confounded by our patient population being young and healthy, so that helps. But I think since we started doing the Bankart repairs, it obviously has helped reinforce that tissue.
Great. Any other questions? Derek?
Thanks for the presentation. You mentioned at the end slide about one of the positives for the study was it was a single surgeon, same site, and you mentioned about the post-operative sort of care. And I'm wondering if you could, what does that look like for these folks? So that, and yeah, can you tell us a little bit about what that is and how standard that is or standardized that is?
Well, it is overall a niche procedure. It's still lateral J, I think, is being done much more commonly in general. There's going to be restrictions with respect to how much mobility they can. We want the graft to heal before the patients go and expose their shoulders in a sort of external rotated, abducted manner. So there is Dr. Wang and team have a specific postoperative protocol that patients follow. Whether that's standardized across North America, I don't think so. Everybody has their own preference. But at least in this study, all the patients would have had the same postoperative protocol, so the variability of outcome would have been limited.
Right.
And that's a strength.
You mentioned it was 3 years, and I looked on your abstract, and it was a range from like 1 to 6 years in your study. So I'm just, does everybody meet the milestones? Like you'd mentioned, the surgeon has the protocol. Did generally people meet those milestones through the conservative care at the same time? So at a year, generally everybody's at a particular spot, or as far as their recovery and healing?
So the group of patients I presented here are specifically the ones that went on to get a revision surgery. And out of 200 patients that we had, we only had 10 patients going that route. So majority of them will actually end up not complaining of anything, not complaining of any symptomatic hardware and so. So the ones that did were that group of 10 patients, and the range was, as you said, between 1 to 6 years. And that has to do with, well, it's multifactorial. It's going to be about how much the original size of their glenoid was, how much the graft resorption, how much screw was sticking out and irritating the subscapularis muscle. So I don't think that part can be standardized, whether that's like if you're referring to that as a milestone. It's going to happen differently for different patients, but it is an area of our technique that we could potentially improve by, and I think the non-rigid fixation that Luke presented before was trying to avoid this screw irritation on the subscaps to avoid these revision surgeries. So that's an area for improvement.
Thanks.
Great. Okay, judges, what are their scores? We got to find some music to play for next time.
That's tough. Going back and forward.
Drum roll, please. 7, 9, 8.5, 7.7. Oh. You have to add this in. Well done, Char. Well done. Okay, so now we're going to invite our first virtual presentation. We have one of our recent fellows, Dr. Jose Castillo. He completed his fellowship with us last year. He did present last year. He's now setting up practice in Mexico. From what I understand, he's actually coming to us live from his operating room. I just saw him in the background. There you go. There's Jose. So he's going to talk to us about excellent outcomes after arthroscopic treatment of glenoid fractures. Welcome, Jose.
It's going to kill me if I do that.
So, hello.
Wait, do we have audio? 1 second here. Testing. Audio? Try something again, Jose.
Yep.
Can we hear you? No.
Testing.
We're working on it. 1 minute.
Okay.
Ah, we can hear you.
Testing.
Perfect. Go ahead, Jose.
Okay, so very nice to see you again, everyone. Hopefully I was there, but it was a couple of miles in between, or kilometers, same thing. So anyway, for those of you who don't know me, I was a former fellow last year. This is a study I worked in last year as well. I'm right now in Querétaro, which was the city I worked through this last year. And I'm moving my practice to Mexico City to join this group called OrthoMove. Okay, I have nothing to disclose. I want to thank everyone in the research team who makes these things happen. And sorry, I'm literally in the middle of the case. So what's a sports surgeon speaking about trauma cases? I don't know, but this is my topic. So we're going to go back to basics in trauma, just reminding how a simple fracture should be treated. And I want to start with this. So a glenoid fracture is a totally different beast as a bony bankard. So a glenoid fracture is a crushing injury of the glenoid against of the humeral head against the glenoid. And a bony bankard, it's an avulsion fracture of the anterior rim. So these glenoid and scapular fractures, they usually happen in the mid-30s in patients with high energy trauma. And also there's another peak with patients with bad bone quality. Patients who go in high energy trauma, 93% of these patients have multifragmented fractures. 88% of these patients have associated injuries. And none of treatment, it's very limited. It's only for non-displaced fractures. On the surgical side, we have multiple options. It could either be open or arthroscopic. Multiple techniques have been described. All the open techniques have their complications of open surgery. And it's quite difficult to reattach small pieces with screws, and they usually overhang, as you see in the picture. The suture anchor techniques, they have been described more for a bony bankard type of lesion rather than a glenoid fracture, and suture button fixation or other types of options. Classification-wise, so same thing. We're speaking about fractures, so AO classification is pretty good. It's very descriptive. You should be taking that into account when you're classifying your fracture. For this one in particular, we use the Adberg and Goss classification, which was described in the early 90s. And the one you see in red, type 1A, it's a glenoid fracture of the anterior ring. It has no extension to the neck or the body, and that's the one that we're going to be speaking about in this topic. So again, fractures. So glenoid fractures. So as a fracture, you can get multiple patterns according to how the energy dissipated. We're speaking of articular fractures, so they have increased risk of arthritis. And also fragment resorption has been described in previous papers. And well, we see that multiple treatment options are out there. So this is how these glenoid fractures have been treated in this center. So both either arthroscopic fracture fixation with buttons or a replacement of the fracture with AAGR with the distal tibia. But I won't go very deep in the techniques. Both of the technique papers are out there. So if there's any question, you can just check them. So what we basically do was to analyze and compare these two techniques, like the fracture fixation versus AAGR. Went to see if there's any difference between the clinical outcomes of the radiographic measurements. So we did a retrospective review from 2013 to 2021 of all the patients with type 1A glenoid fractures. We found 41, which included 3 patients that were treated with open surgery, and we obtained 12 patients that were treated with fracture fixation and 20 treated with AAGR, and this is what we found. So these are demographics, very comparable between the two groups in age and all those type of things. The only thing that was significantly different was the combination rate of the fragment between the two groups. So it was significantly higher in the AAGR patients. And you can also see that the glenoid bolus is very similar in both groups. When we see the glenoid A to P dimensions, we can see that both of the groups are also very similar. In both of the groups, this A to P dimension was increased from pre to post, and there was no significant difference on the post of both techniques. Regarding the PROs, same thing. So very similar between the two groups, no significant difference. And well, we see that both of the techniques were well. So fracture fixation or AAGR, both of them improved the glenoid width, improved the clinical outcomes. If you go back to basics, like they're technically easier than, for example, trying to do a bridge with sutures. And well, you know, that's easy to learn here. So same thing, the only thing that was different between the two groups was the combination rate of the fracture fragment. And most of these patients were treated with AAGR. So strengths of our study is the first study comparing the fracture fixation technique and AAGR. Very good clinical follow-up. It was a mean follow-up of 3 years, radiographic follow-up of around 1 year. Weaknesses very similar to the other studies. So in this particular case, small sample size, retrospective study, and well, it's a single center, single surgeon case series. Okay, so again, when we have a fracture, it's not the same thing to have a totally smashed tibia in a million pieces or a simple fracture. So the same thing, same basics are applied here. So if you have a big piece of bone that could be fixed or reattached, just do it. Like it's not a big deal. So the technique with the suture bottom works quite well. It's easy to do. It's a very quick surgery. And if the piece is in a million pieces, it's going to be painful to reattach or to try to fix. Just replace the piece with AAGR, distal tibia, and you're ready to go. So they're very compatible. We just choose the right patient for the right operation. So AAGR and fracture fixation, we know that both restore glenoid dimensions. They have similar patient-reported outcomes. and a low complication rate. So back to basics, trauma, 3D imaging, good imaging, pre-operative planning, and good surgical decisions will take you to the other side. And I miss all these people who was there last year. Hopefully a couple of them are there, and I'll send you a big hug to everyone.
Thank you very much, Jose. Very good. Any questions from our panelists?
Okay, I'm just curious, do the buttons work better with?
Sorry, he can't hear you.
Jose?
Yeah.
I don't know if you heard the earlier talk comparing the button fixation to screw fixation with AAGR.
Yep.
So do you have any comment? Because on this one, you're showing that with native bone, does it look like the cortical button fixation works okay?
Yeah, so I think, so yeah, same thing. It's a totally different problem. So it's your own bone. Ideally, it should be an acute fracture. So it's going to be a bone that's going to be healing way faster than a frozen distal tibia. So I think that's the thing that could explain this. So we have a pretty good clinical follow-up and a very good radiographic follow-up that supports using buttons, at least for fractures.
Great. Any other questions? So yeah, this is different. Oh, Derek.
Sure. Yeah.
Go for it.
Jose, thanks for the talk. And I noticed just with the other talks and in yours, you were the one in your abstract. You mentioned this idea of progression to osteoarthritis with all of these surgical techniques that we've been talking about tonight. And I'm wondering, how often does that happen? And are there certain patient characteristics or things you can do now to prevent the later development of osteoarthritis? Because that certainly has an impact of a lot of the techniques we're doing now later on in folks' lives. So can you comment on that?
Yeah, correct. Yeah, thanks for the question. So yeah, certainly. One of the things, even though it's a small case here, is we went looking back to these patients, and one of the things that we saw that was affecting the most is the time to surgery. So the sooner you get these patients done, the better they do arthritis-wise.
Thanks.
Very good. Yeah, I think that's one of the biggest things. We'll talk about more about arthritis coming up. So Jose, we have to say, this is your birthday, so thank you very much for coming on your birthday.
Thank you for the invitation. Thanks for having me, and it's nice to hear your voices.
Happy birthday. We're very proud of you. Keep up the good work down there. And for those of you that don't know, Jose is actually going to represent us from Dalhousie at the ICSES conference in Rome in September. So he's going to come represent the Dalhousie group in Rome because we have many papers that have been accepted, and he's kindly going to go represent and present. So thank you. We'll see you soon.
Yeah, of course. Bye-bye. Nice to see you, everyone.
So we have to ask our, we have to do our scores. I'm sorry, our scores from our panelists. Jose, you still on there to watch? Oh, we lost Jose? Hopefully he didn't log off. He's still there. Okay, scores, 8, 9, 8.5, 8.2. Oh, this is gonna be really tough. So I didn't add all these up. I think we're actually gonna put the 4 panelists in a room right now while we do our annual research night. They're going to deliberate here on the side to try to figure out who it is, because we're going to give the award right after this. So I get the privilege of kind of going through what we've been up to for the past year. This, again, is the 11th annual Dalhousie Sports Medicine Conference, or Sports Medicine Research Night. We have a wonderful gathering. This, again, I think is bigger than every year. We got our colleagues here. We have our fellows. We have our past fellows. We're going to introduce our new fellows shortly. We have our research collaborators, residents, students, our nurses, our physiotherapists, our industry partners. So again, thank you guys for coming. You really help support us. This is a big team, and we're here really to change the world. We can never do everything without our industry sponsors, I must say. We try to do many different things, and we do have to say thank you. We recognize we do need a lot of support for this. These companies here, Bioventus, Stryker, Spring Loaded, ConMed, Smith & Nephew, and Bauerfeind, has helped to contribute to tonight's event. They've helped to sponsor our students, our residents, our fellows, extra seats to be able to help us perform and gather and kind of celebrate the successes of our fellows, both present, future, and even past. I could never do this without our team. Our team here, I tell you, is second to none. I'm super proud of them. We'll talk more about them every time that we go out. We have Matt Miller, we have G. Ma, we have Sarah Remedios, we have Morgan King, we have Lasha, I still didn't say his last name right yet. We have Devin Penkura, and we have Noah, and we have our admin team. Okay, we have Mandy Wells, we have Hannah Burns, Michelle McLean, and Pamela Shears. Of course, we have our fellows, the fellows this year from COVID. We have Dr. Kazu, we have Dr. Luke, we have our Italian fellow. He was not able to join us because of COVID, but we in general have 3 fellows a year coming through. So we're very lucky to have all these big team here in sports medicine at Dalhousie and Nova Scotia Health. This year has been really busy. So again, every year seems to be busier. Our map grows every year. We did a total of 71 presentations worldwide. You can kind of see a distribution of the map. That really, we haven't hit the African continent yet. We have a fellow from Kenya who's going to definitely help us get there. I guess the only other continent is Antarctica, so we're really not hoping to go there. We started off the year in San Diego, so Kazu's been with us for a year and a half. So he started his first time with us, just like McKenna, at a presentation. So started off a presentation at San Diego. We had multiple demonstrations, live cadaver labs down there. We've moved on to NOLA, New Orleans. So New Orleans was a nice course. We had our fellows down there helping to demonstrate, helping to present. We've demonstrated our techniques at Boston OSET. OSET is the Orthopedic Summit of Evolving Techniques, so it's one of the highlights of the year. Many subspecialties. We highlighted how we're using holograms, HoloLens, augmented reality to be able to help in our surgery. We've demonstrated our techniques at the Advanced Shoulder course in San Francisco. You can see we have good food down there too. But lots of labs, lots of surgeons wanting to learn, trying to get together to be able to understand how to do these different techniques that you've kind of seen the outcomes from tonight. At the Academy, the largest orthopedic meeting in North America in Las Vegas this year, we actually were highlighted quite a few times. We're on ICL panels. We have multiple surgeons coming to figure out how we do things, where we do things, and presented at many different booths. In fact, we were actually highlighted to be at the 4K demonstration theater where we were actually showing live the HoloLens, how we actually demonstrate and how we utilize this in surgery to improve our outcomes in hip arthroscopy and shoulder arthroscopy, to the point that the FDA actually came up to use us as a consultant to be able to help validate this type of tool in the operating room of the future. We've gone back to New Orleans at ANA. ANA is the Arthroscopic Association of North America. We were actually highlighted there quite a few times throughout the day to be able to show what we can do on the podcast, as well as having our fellow, Dr. Luke Heinrich, win the Innovation Award from Dr. Steve Burkhart. So this is an annual award of which this is the second year, and he was the person winning this prestigious award.
Ooh,
Next, moving on to Shoulder 360 in Miami. You can see 2 of our fellows there on the Instagram post. They were definitely one of the highlights of the meeting. We have shoulder experts from all over the world coming here. That's Dr. Laurent Lafosse, who actually invented the arthroscopic latterge, so he's well known throughout the world, and be able to showcase what we have to be able to help improve on this type of a procedure. Next, just recently, last week, we've moved on to Boston in ISAKOS. ISAKOS is the International Sports Medicine Conference. Includes arthroplasty actually in this. And we've had Dr. McKenna, who's actually won the international award for that as well. So we've been very successful. And of course, Kazu here enjoying his favorite game of baseball. And just last week in COA in Calgary, we have our entire team. You can see in the top right corner is our past fellows, our present fellows, and our future fellows all together. It was a really good time to see. They're able to enjoy the Calgary Stampede going through here. having, again, multiple presentations. I think during our specialty day, Dalhousie was highlighted in more than half of the presentations throughout the entire day. I believe it was a total of 8 presentations, so it was really, really nice to see. We were actually invited to the Shoulder Instability Study Group Congress in Grenoble, France. So this is actually a European shoulder instability group. So if anyone who's doing shoulder arthroscopy or taking care of shoulders realize that the European surgeons essentially completely do Latarjet. So it's very interesting to be the sole North American invited out to this group to be able to actually hopefully change the way we're going to study shoulder instability. So recognizing that what they're doing has been good and is the gold standard, but there is a lot of problems with this, and they're looking to the future to try to find out what next to do. We've been invited to grand rounds all over the world. So this is one of the grand rounds. So this is Vail Grand Rounds. We're actually, again, everyone is very interested in how we're able to utilize augmented reality in the operating room to be able to improve our accuracy, improve the way that we can teach this, and be able to teach this all around the world without even having to travel. We're invited to Singapore. This is the Inspire meeting. You can see there's several Canadians. There's Ian Lowe out here. There's Al Get Good as well. So we actually have a very good Canadian representation at major international meetings to be able to showcase how we do things in Canada and to be able to spread this knowledge worldwide. Virtual lab training, so it actually comes back to Halifax as well. So this is our ConMed group who actually brings in virtual reality to be able to help teach surgeons and residents and fellows. So we've actually have our own virtual reality lab here to be able to showcase how we can do rotator cuff surgery better and collaborate and be able to do this in a very repeatable manner in the virtual space. So hopefully you've seen, we've been very successful at talking about global education. And so from 2014 to 2023, so over the last just about 10 years, there's more than 135 surgeons across the world that have come to Halifax to learn surgical techniques, and you can see the countries that you have here. Over the past year, our outreach has actually been quite good. We've had 61 surgeons come to visit Halifax, either virtually or in person. You can kind of see where they came from, so a lot from, mostly from North America, but also from Japan. We've had virtual broadcasting of our surgeries out around the world as well, 33 of these from around the world. We actually were the main site to showcase live surgery to Pune, which is their largest Indian Arthroscopy Association. It's actually on their open access for viewing so that they can actually learn the techniques that we've designed here in Halifax. We've actually now taught virtual cadaver labs across the world. So this, over the past year, we've done 19 of these labs, really across North America. So where the surgeon is in their home site, we are in Halifax, and we can actually instruct a surgeon how to do a completely novel operation without ever going to see them. So we've never met these surgeons, and being able to teach them how to do a complex surgery without ever meeting in person. Of course, in person is always great because we get the conversations outside. So we've had 9, even though it's just after COVID, we have 9 surgeons actually followed in. This is Dr. Chris Rajaratnam, one of my actually mentors from McMaster University, came back to learn techniques here in Halifax. We had Dr. J.P. Warner, who is actually the head of Mass General of Harvard, actually come up here as well. We have Dr. Sochi Uchida and his partner up from Japan to come down. They are the head surgeons from Japan, from Tokyo. We have Dr. Uma Srikumaran. He's actually the head of Johns Hopkins, who's come down as well amongst this. And we've had several other elective orthopedic surgeons who actually want to come and potentially do fellowships here in Halifax. We've also been very productive. Our research team, our fellows, our staff, we've actually published 26 papers in major orthopedic national and international journals in just the past year. So really big influence on all our academic work. We have co-authors from all these papers in 33 countries from around the world. So we're really trying to make sure that we're very collaborative, be able to distribute all this information, again, globally. Some of the highlights, even locally in the QE2 Times, they're actually acknowledging that we're doing some augmented reality to be able to improve patient outcome. Awards, just like we mentioned, Dr. Luke Heinrich has won the award. This is actually a very difficult award. We've actually won this from Dalhousie. We've won this 2 years in a row, the Stephen Burkhardt Award for Shoulder Innovation at ANA. Dr. Cody has won the Medical Student Teaching Award for Orthopedics here at Dal. I was presented with 2 awards at COA for Innovation Award in Arthroscopy and Sports Medicine. And I've just finished concluding my presidency as the Arthroscopy Association of Canada. This year also been successful getting grants. We have just got our CIHR, so Canadian Institute of Health Research grant for just over $400,000 looking at arthroscopic treatment for recurrent shoulder instability trial, our bone block techniques that you just finished seeing many of the presentations and publications on. And this is a national multi-center trial. We've received 2 other grants looking at the comparison between the current gold standard Latarjet versus AAGR and 2 of the most established societies in the world. So the American Shoulder and Elbow Surgeon Research Grant, as well as the Arthroscopy Association of North America Research Grant. And finally, we got to welcome our new fellows. So why don't we stand up here, because we also, hopefully, is Dr. Karpashian online as well, and can she turn on her camera? She's still back in Edmonton, just packing either that or in transit getting back. Here we go. Welcome, Jill. We have Dr. McKenna McBory from Kenya. And we got to get the lights back on. And we have not had a presentation yet, but Dr. Emily Chan has just joined us. She came straight from the COA, coming from Saskatoon, Saskatchewan. There we go. Now everyone can see her. So we're really excited. We got big shoes to fill. Every year our fellows seem to get better and better. So welcome to Halifax. Look forward to having you down. Jill, do we have an answer for who's going to win? Who's going to present this?
So it was a tight race, as you guys know, and everybody did an awesome job with their talks and their research presentations, but our winner is McKenna.
Welcome.
So we're going to go to the next presentation. Yep.
Congrats.
Yep.
Congrats.
Yep.
Sorry, we gotta get. So I guess right now we have to change the scene. We have a few more awards. We're getting our fellow presentations while we get that set up. So we'll invite, who's first, Luke or Kazu? Luke? Who's tallied up? Luke.
Is he here? There
You're
he
on.
is. Yep.
Not quite.
Oh, thanks everyone. I hope this isn't judged too, but so I have nothing to disclose with this talk, first off. So growing up, I'm originally from Saskatoon. It's a small city on the prairies out west. Some of you may have heard of it. Named for the Saskatoon berry, I guess. I'm actually, I guess, the first one from Saskatoon, but now we have Emily, also from Saskatoon, so I get the distinction of first Saskatoon fellow. Saskatoon is very cold in the winter, but just beautiful summers, so I encourage you to visit someday, but just make sure it's in the summer. Here are some pictures of me growing up. There's my little brother, myself, my parents. And growing up, my major sport was swimming, actually. So here you see a picture of me. My team was the Saskatoon Lasers. This was probably about 2005. It was at Age Group Nationals in Calgary. You see the Talisman Center. But a lot of fun, a lot of time with the head down the pool, but you know, it kept me busy. Don't have a lot of videos from back then, but predating smartphone era, but there are a few around. The other highlight from my swimming is I met my wife. So we actually started dating when we were 16 years old. This is Tia. Tia, interesting fact about her, she comes from a big hockey lineage. The guy on the left is a goalie named Rick Costi, so that's her uncle on her mother's side. He played in the Olympics. And then on the right, you see her dad, Tim Chevelday, who was a goalie drafted to the Red Wings, played for multiple NHL teams. So I always like to say if my boy doesn't make it in hockey, it's definitely my fault. Another member to introduce in my family is Morty, our 10-pound Pomeranian. You can see he was very cute when he started. That's probably why we got him. Interesting fact about him, when he was a puppy, he leapt off our couch. Someone was dangling something, broke his arm on a coffee table. Very expensive surgery for as a medical student. But he seemed to have healed up okay, but $50 screws. Not to belabor the traumatic point, but subsequently to this, my wife was driving and totaled our car. Our dog hit the dashboard very hard. Since then, he's had really bad travel anxiety, which will come up a little bit later in this talk. So my next stop after Saskatoon was Edmonton, another flat city, very cold, very warm, recurring theme. Below you see the whole resident group. There's actually Jill in the middle there looking like she's playing the piano. And then on the right you see me operating on some extremity, not exactly sure what. For some reason I decided to have not one but 2 children in residency, the second in my final exam year. Don't recommend if you like your sleep, but I made it through. The other thing I did during residency, interesting, I did some autocross. You can see my collection of Miatas that somehow I fit into. On the right, you can see me trying to fit a car seat and a toddler in a 2-seat convertible. Generally not recommended, but eventually I switched to a minivan. My next stop, of course, Halifax. So for this year, I don't think I realized how far this was when setting out. It's basically the same distance to Ireland when I checked the math. But it's just been a great year. I spent a lot of time exploring Macintosh Run on my mountain bike. I did end up having a bad fall on my bike, but surprisingly, it wasn't on a mountain bike. It was just me on my road bike commuting out to Scotia. I had a bad fall at the bottom of McDonald Bridge and actually ended up tearing my meniscus a little bit. I still showed up for first case though. Dr. Cody did notice my bloody leg at the end of first case, but eventually I got a decent dressing on it. Halifax was an interesting year. As a prairie boy, I was just used to the occasional thunderstorm, but seeing some actual natural disasters, interesting. Of course, we had the hurricane. I saw walking around, I ran around Point Pleasant Park the day after, and you could see even someone skateboarding on the broken sidewalk. A cold snap, it was a big deal to everyone. Didn't sound like a big deal to me, but our dishwasher did freeze that night. So I guess the houses just can't take it. And then, of course, a series of fires. But it's just been a great year. I met a great group of fellows that I had the opportunity to become quite close with, a great group of residents and staff to all work with. Yeah, it's just been a wonderful group of people. We've had the chance to make a lot of friends with not only our kids, and we're quite sad to be going. I guess I better hurry up. But of course, we were down in COA where we got reintroduced to the West with a pretty lame rodeo. Going back to this point about moving, you can see here we just moved last week back out. We're heading out to Medicine Hat now. You can see this is the flight that somehow my wife survived. 2 kids, anxious dog, whined the whole time. My wife, about halfway through, said basically she hoped baby would start crying to take away attention from our poor dog. But she was well prepared with these snack boxes and everything for our kids. And you can see I was helping out too. So we're moving down to Medicine Hat. It's a small town in southern Alberta, quite beautiful. Beautiful new ORs, all renovated, and we're quite excited about that. Lots of mountain biking. There's rattlesnakes down there. There's kind of, I think, mythical stories of people getting flat tires from rattlesnake bites. I don't really believe that. But of course, we're excited to be close back to some serious skiing, and you know, I'm looking forward to coming back out for COA next year. I have a few bucket list items. Dr. Cody knows I wanted to get a picture on the Black Rocks, so you know, that's still on the bucket list, and then of course getting down to PEI. But yeah, thanks again. It's just been a wonderful year.
Okay. Okay. I just came from last year, January, and 2022, and I spent a great time, you know, totally 1 year and 6 months. And just I came here, Maud and Jose, the great partners, and we enjoyed skiing. That's my son, and that's my wife, and also Maud and Jose as a family. It's wonderful. So totally more than 10 times went to Matok. That's wonderful. 45 minutes drive.
You two are showing up, and I'm leaving. You must have got the kids, right?
What's that?
You got the kids?
No.
And really great time with Luke, and he's a great my son and swimming teacher, and also with Luke's son Eric, my son is sweet, playing PlayStation, and that's a great time. Thanks, Luke. Also, we went to so many times in a PEI because for many Japanese people, PEI is most sanctuary place. And unfortunately, teacup storm already gone. So before, just 1 month before we went there, that's most memorable picture in our family. Also Miami, that's great. Matt, he's the most crazy man there. I love him. Also Reza coming from Ottawa, that's great night. The same hotel room, that's so fun. Also great staff, everybody very collaborative, very supportive, really appreciate it. Also, thanks to Dr. Wan, so many chances to get in touch with other fellows. That's fellow Kennedy fellows, sports medicine, also upper extremities is a great social network. Also, I really respect Dr. Uma Srikumalan. He kindly answered my question about my future practice, what I have to be care about in the next stage in Tokyo, Japan. He's really nice guy and really appreciate his professional, academic, everything. Also, between cases on call, Dr. Wan brought me to the warehouse and so many scallops, so many lobsters. That's exciting on call days. So the new fellow is so excited to having dinner between cases, hopefully. Also, I really appreciate Dr. Melinda Coker. About more than 10 years ago, in my medical school final year, I got a chance to 1 month clinical rotation in Boston Children's Hospital, and I stayed in his house, and his wife and his kid is so nice, and he got me into the sports medicine. And just Isakos, just 2 weeks ago, I met him, and he will come to Japan, Tokyo this winter. I'm so really happy to meet him. He's a great guy. Also, Dr. Charlie Brown, he is a big knee surgeon. Just 5 years ago, I went to UAE, Abu Dhabi, just to see his surgery. And he's also extremely respectable, professional knee surgeon. I love his surgeries. And I met him, just his casual costume. So it's very casual pictures. I'm very, very happy to meet him in Isakos. Also, that's connecting dot. Dr. Cody did a fellowship in Boston Children's Hospital. Just coincident, just my first step in sports medicine, Boston Children's Hospital in my final medical school year. That's Dr. McCallie and Dr. Melinda Coker. I think that's Dr. Coker's the same team. That's great. Also, left side, Dr. Ofemi Ayani at McMaster. Dr. Ofemi Ayani is Dr. Ivan Wan's and close friend. And also, left side, Soshi is new Isha HIP International Society president, 2025, and also close friend with Dr. Ivan Wan. And hopefully, we are happy to invite Dr. Ivan Wan 2025. Also, and Dr. Dr. Arkert did completed fellowship at McMaster, and also Dr. Ofemi is the same team. So it's surprising because before I came here, I did not at all. Dr. Cody did training in Boston Children's Hospital, and also Dr. Nathan Arkert did a training with Dr. Ofemi Ayani. But before I came here, I didn't know it at all. But that's connecting dot. Interestingly, now any dot connected successfully. And last week in Boston, in Isakos, I met everybody. That's so nice time moment. All dinner, all lunch, all discussion, knee surgery, shoulder surgery. So excited, so happy. So I'm really, really appreciate it. Finally connecting the dot. Thank you. And also, I'm, to be honest, my best mentor, Dr. Ivan Wan. Without his help, I'm not be here. And very now emotional. So he's a he's a great guy. Yeah. Yeah. So my future team, Sochi, presenting 2025 International Society HIP Arthroscopy in Tokyo. Also, Dr. Hayashi is a many professional chief physician. So I'm so happy to get a position in Tokyo, Japan, as our third primary principal orthopedic surgeon. So that's definitely, without Dr. Ivan Wan's help, I would not get this wonderful chance. I'm so honored to have a training with Dr. Ivan Wan. Thank you. And that's my most memorable presentation in COA. So, Canada is very welcoming, very kind. Unfortunately, it sounds not enough, so it's a moment you have to laugh, so but no laugh, so it's okay. Thank you all. Thank you.
Good job, Kazu. We just gotta give you your certificates. Okay, we're gonna move on to the last bit because I know we're a bit over time, so I'm sorry about that. We're going to invite Dr. Cody to give our first award. We have so many people to thank. This is just a small token because without all of you, we can't get what we want done.
Okay, thanks. So I'm not going to say who it's getting to because I want you to hear what it is. So this is a nursing award, and this one is being honored to a specific person because of her exceptional patient care, technical proficiency, and leadership abilities. Her compassionate approach, deep understanding of surgical operations, and dedication to continuous improvement have made a significant impact on the patient incomes and the advancement of orthopedic nursing. Her unwavering professionalism and commitment to the ethical standards further highlight her outstanding contributions to the field. We want to thank each and every nurse in every capacity that help us every day in all of our clinical settings. But the nurse and it made it very difficult to pick just one person, but the person we chose was Susan Taleb.
Honored to work with you guys.
So our second award is going to be for a medical student award. So this medical student is very talented, has been collaborating with us in the sports medicine group for several years, has helped to do research advancing medical knowledge through his association with our team. He's displayed meticulous analytical skills in publishing 2 peer-reviewed international papers, reflecting his ability to tackle complex problems at a very young age. He is a very high prominent, high potential resident now. Trying to figure out where else we're going here. And he has been able to present these findings at, again, national meetings. We're hoping that they're going to be our international meetings coming up in future. So our Research in Medicine student of 2023 goes out to Malik Ali.
Okay, so our next award goes to another resident, and this resident, you might be able to figure it out as I keep talking, but is now, will be a fifth year, in orthopedic surgery at Dal. He's been an invaluable member since 2019. He's made significant contributions to the field through research, including publications of 3 notable works, 1 peer-reviewed book chapter, 1 systematic review paper, and 1 research paper. His research findings have also been shared through presentations at over 10 national and international conferences, sparking discussions and driving progress in orthopedics. With his strong foundation in orthopedic surgery and unwavering commitment to research, we are happy to present this award to Dr. Mo Awad.
So the next award is in recognition of continued achievement from Best Former Fellow Award for 2023 is Dr. A.P. Dalhousie Ravi. Dr. Ravi is a highly accomplished sports medicine specialist from India who made significant contributions during his fellowship at our institution from 2018 to 2019. With a passion for advancing the field, Dr. Ravi delivered over 10 presentations at national and international conferences, showcasing his excellent research skills and providing valuable insights to the medical community. He also contributed to the field through 6 influential publications published in prestigious journals and received the 18th Annual Conference of Indian Arthroscopy Society Gold Medal Paper and AAC Best Fellows Paper Award in 2019 for his innovative research. Recognized for his outstanding achievements, Dr. Ravi was honored with the Continued Achievement Best Former Orthopedic Surgery Fellow Award. His unwavering dedication and remarkable contributions made him an exceptional professional, inspiring the practice of sports medicine and leaving a lasting impact on both the medical community and his patients.
Thanks, Ravi. You're on stage. Can you see us? Ravi? Oh, we don't have audio.
And Dr. Cody, can you hear me?
Yes, we can hear you. We can't see you anymore.
So thank you. Everything I've achieved, I've already said this before. Thank you, Dr. Wong and Dr. Cody. You have helped me not only shape as a surgeon, but as a person in general. As the person was on the stage from Nova Scotia Health was saying before, how do we translate work that we have done in Canada to other parts of the world? I'm very glad to say that we are translating this work that I have learned in Halifax in India to help the people over here. The fact that I have 2 regenerative patches posted today in OR is indicative of that. Thank you for shaping me as a surgeon and as a person overall. I also would like to tell the incoming fellows that this is an excellent place to learn and use this opportunity to grow. Thank you very much.
Thank you, Ravi. We are very proud of you. Keep up the good work. Okay. So we are sending you your award. I'm sorry we were hoping that it would get there right now, but India is a little further for us to send this award than we thought. Okay, so it's in the mail.
Yeah, it's on the way. It's on the way. I think I'm tracking it very closely. It's in customs of India, so I think I'm going to reach it.
Thank you. Thank you, Ravi. We're very proud of you. So we'll move on to our next award. Our next award goes out to our research team, because I'll tell you, without our research team, we can definitely not be as productive as we are. We probably are on par with every major orthopedic department across North America, and their teams are way larger than we are. So we are batting way above our level here. This one, it was very, very hard to choose. I must say, we want to give an award to every single one in this team. This individual is a distinguished researcher whose relentless pursuit of knowledge and significant contributions have propelled her to new heights this year. In the past year, she's moved from a leader into a leadership position on our team. She started her PhD. She continues to create innovative projects for our research portfolios. She leads with kindness and determination, motivating our team to become a cohesive unit to achieve more than we can ever imagine. She's an excellent researcher, an outstanding recipient for this award, and is receiving, in recognition of excellence in arthroscopy and sports medicine research, not doctor yet, but Sarah Remedios. Congrats. Okay.
Okay, you're getting close to the end. Next one is for one of our fellows. So this fellow is being recognized due to exceptional commitment to personal growth, dedication, and transformative impact within the Dalhousie Joint Preservation, Sport Medicine, and Arthroscopy Fellowship Program. Through his tireless efforts, this person has consistently demonstrated a remarkable drive to improve himself both as a physician, as a researcher. His ability to foster collaborative and supportive environment has resulted in significant advancements and positive outcomes, making him an outstanding recipient for this award. And we now have heard his the fact that he has got the most views on View. Mehdi Kazoo, come on up. It's for you.
And so last but not least, we have our Educator Award. And I'll tell you, well, of course, it's Dr. Kathy Cody. She's a remarkable educator, unwavering commitment to teaching excellence, left an undeniable mark on Dalhousie sports medicine. Okay, with her passion, she inspires and empowers her students. She has consistently gone above and beyond to create engaging, transformative learning experiences. Her instructional methods, combined with her genuine care for every single learner, has set her apart from others. Through her tireless efforts and enthusiasm, she's proven herself in teaching excellence, shaping the minds of future surgeons, fostering a love for lifetime learning. Dr. Cody, thank you. So this concludes our night. I gotta thank you. You stayed to the end. Really appreciate it. We can't do it without you. We appreciate the support. Bring our fellowship team up here. We thank our panel members. They're still here. Our sponsors, our presenters for a memorable night.
Special thank you to all our guests. We would not be here without you.
And thank you for all attending. We look forward to seeing you guys next year.